themselves for evidence of trauma. I didn't mention it with the pelvic limbs, but sometimes, particularly in greyhound breeds, you can see pad corns or warts as a cause of lameness. Each of the phalanges, now I'll direct my attention to the metacarpophalangeal joints and their associated sesamoids. We'll run those joints through a range of motion, and then we can palpate up through the metacarpus, both soft tissues and bony tissues. We'll feel for carpal effusion. I'll run the carpus through a range of motion. For an older guy, he's got great carpal flexion, can put his pads on the back of his antebrachium, has full carpal extension, and that's pain-free. We can test him for varus and valgus instability. Notice that in the carpus, especially this flexed carpus, they have this funny drawer sign. That's actually normal. Now I'm palpating the accessory carpal bone and the insertion of the flexor carpi ulnaris upon it, feeling for swelling, much like you were feeling the Achilles mechanism inserting on the tuber calcis of the pelvic limb. Working my way up the soft tissues and bone of the antebrachium, and now getting to the region of the elbow. So here's his lateral epicondyle. There's the olecranon. And when I'm feeling for effusion, I usually feel for it between those two structures. So right about where my thumb is where I would feel for effusion. That feels good. Now I'm going to assess range of motion. He's got full pain-free elbow flexion. He can place the point of his shoulder against his distal antebrachium. And I'll evaluate him for discomfort on extension. If I'm too forceful, I can make a dog with a healthy elbow uncomfortable on forceful elbow extension, but he seems fine. And now we'll promenate and supinate him by placing his carpus in 90 degrees, his elbow in 90 degrees. And I'll pronate, and I will supinate. And that doesn't seem to be uncomfortable to him. As I feel his humerus, I have to be aware that his radial nerve courses right through his musculospiral groove, or in that region. And so if I'm too forceful as I squeeze on his humerus in that region, it may be that I'm just pinching his radial nerve. Feeling his triceps. So now we can extend his shoulder, recognizing that his shoulder is extending and his scapula is gliding along his thorax. And now we'll flex his shoulder, and that's very uncomfortable. And so that is suggestive of a tendinopathy, whether it be supraspinatus, biceps, don't know just yet. Now we're going to externally rotate his shoulder, internally rotate his shoulder, and now we'll do the biceps traction test. And we'll do that by placing his shoulder in flexion as we gradually extend his elbow. That begins to stretch out the biceps tendon. And I'm going to feel over the region of his biceps tendon origin on the medial side of his greater tubercle. And that's uncomfortable to him. And indeed, he has been treated for a biceps tendinopathy in the past. And while his gait has improved under that physical therapy regimen, he does still have some biceps tendon discomfort. He has also been treated for an insertional tendinopathy of his supraspinatus tendon, the muscle group on the cranial aspect of the scapular spine that comes down and inserts here on the greater tubercle. At times in the past, he's had insertional discomfort on the greater tubercle, but today that does not seem to be associated with discomfort. And now we'll palpate deep in his axilla, and this can sometimes be used to detect axillary masses. So this is the region of his pectoral muscle group, passing from his sternal area to his proximal humerus. And I'm going to place my thumb up behind the pectoral muscle group, and my fingers are actually going proximal to the pectoral muscle group as they span the region. And with this, I can feel deep up in his axilla. And he's got no evidence of discomfort or space-occupying masses in this region. Now let's do a recumbent exam of the front limb. Note that we have our patient on a padded raised platform that allows me to sit alongside the pet on a rolling stool. And this is a nice solution for those of you who have some mild to moderate mobility issues of your own. Now at this point, there's really no difference than what I've shown you previously to date. I'm palpating the pads, in between the pads, palpating the digits, etc. We'll feel the metacarpophalangeal joints, palpate the metacarpus, assess range of motion in the carpus as well as the elbow, etc. What I did not show you during the standing exam is how to measure the shoulder abduction angle as a means to evaluate for medial shoulder instability. For this exam, it's important to be able to palpate the scapular spine so that you can hold the scapula stable against the body wall. Now position the shoulder into full extension. Then slowly abduct the shoulder. Now this can be an uncomfortable maneuver even in patients with a healthy shoulder, so be sure to go very slowly. And remember, it really is an instability test. A painful response is not necessarily relevant or significant. Instead, I will assess the abduction angle and compare that of the right shoulder to the left. The abduction angle is the angle formed by a line drawn parallel to the table surface and a second line drawn down the axis of the humerus with the shoulder held in maximal abduction. Now you can actually use a carpentry app on your smartphone to help measure this angle. Now when I get an abduction angle that's greater than 45 degrees, I start to become concerned about medial shoulder instability. This is especially true if the abduction angle is 20 or more degrees greater than the contralateral asymptomatic shoulder. Now there's 3 points of emphasis that I want to make. First, as I previously stated, it's important to stabilize the scapula. If I don't stabilize the scapula, abduction of the limb causes the scapula to merely glide along the chest wall. Second is if I do hold the scapula down, but I allow his shoulder to flex, even normal dogs will have a very large abduction angle. Third is if pain is preventing you from performing this maneuver as precisely as you'd like, that may be an indication for sedation, and this can be combined with relevant diagnostic imaging. To palpate deeply into his axilla in this position, his pectoral muscle group's right here, and I can slide in behind his pectoral muscle group, in this case with my thumb. On the opposite shoulder, it would be my fingers. But I'm feeling for masses as well as areas of discomfort up in the area of his brachial plexus. And you can see that with my fingers, I'm able to reach over the top of his pectoral muscle group, and I'm able to reach approximately halfway up the medial surface of his scapula. So I'm getting a really nice deep palpation up in this axillary region. Well, thanks a lot for spending some time with me, and I hope that you have found this video helpful. Now here's a tip you may wish to consider for analyzing the gait of small breed dogs, is use of a selfie stick and smartphone to film the gait from the side as well as from behind or in front of the dog. We all know that small breed dogs, it's difficult to get down at their level to visualize their lameness, and the selfie stick can certainly help in that regard. Another challenge with small breed dogs is the rapidity with which they move their limbs. Again, by using the selfie stick to capture the video and then taking the video and putting it in slow motion, we can oftentimes see a great deal more detail regarding the dog's gait. We're going to take a look at a 10-month-old golden retriever that has been lame on her right front limb for 6 months. The breeder suggested the lameness was most likely due to growing pains, probably referring to panosteitis. It is important, however, to point out that panosteitis typically causes a lameness that shifts from limb to limb over time, and that was not characteristic of this dog's lameness. At a stance, we note that the dog typically will stand with the right front paw rotated externally. This is a relatively common stance posture for dogs with medial elbow pain. Next, we're going to take a look at the dog's gait when viewed from the left side. It is worthwhile to point out that all of these videos were shot with a smartphone and a selfie stick, so this is not very sophisticated equipment, yet it gives us very good analysis of the dog's gait. During the observation of the gait, we can see that there is a subtle head-bobbing lameness. Slow motion video is typically available on most smartphones as an app or even as an inherent feature of the phone itself. It can be really helpful in determining which side is most affected by the lameness. And here we can see the dog is willing to bear weight on his left thoracic limb, but tends to lift his head on the right thoracic limb. So head goes down on left, up on right, down on left, up on right. And the saying is down on sound. They're willing to bear weight on their sound limb. I like to view the gait from multiple perspectives, and in this case viewing the lameness from the front, again using a smartphone and a selfie so I can get down at the level of the dog, gives us a much better view of the lameness. And it's very clearly a right thoracic limb lameness on this view. Slow motion video can also be helpful in client education because sometimes the owner is very convinced that the lameness, perhaps in this case, is the left front limb. And by showing slow motion video, I can characterize and justify exactly why I say the lameness is in the right thoracic limb. With regard to the assessment of possible panosteitis, we should point out that on exam there was no pain detected upon deep palpation of the long bones. Here I'm evaluating passive range of motion of the left elbow, and there is a full range of motion present, with only very minor discomfort noted upon extremes. Next, we'll direct our attention to the right elbow, and I should point out that I'm only showing the elbow exam, but a complete exam of each thoracic limb was performed. On full flexion, actually the dog rolling over may well have been an attempt to avoid full elbow flexion. Here discomfort is noted on forced elbow extension, but even more significant to me is the discomfort noted on forced full flexion of the right elbow. I should point out that while the patient's responses seem relatively mild, one of the reasons that I'm comfortable attributing them to pain is that I performed these maneuvers on multiple occasions rather than relying upon the patient's response to a single stimulus. So in the end, I was quite confident in my assessment that the patient had a grade 3 out of 5 right front limb lameness that localized to the right elbow. Next, I reviewed radiographs made by the primary care veterinarian to screen for the presence of panosteitis, as well as to look for other explanations of the lameness. On this radiograph of the left elbow, which is relatively asymptomatic, I see no evidence of sclerosis within the intramedullary canal of the diaphysis, as one might expect with panosteitis. But I do see very subtle sclerosis in the region below the trochlear notch adjacent to the medial coronoid process. This is indicated by the arrow. We'll compare these radiographic findings to radiographs of the right elbow, the more clinically affected of the limbs. Again, we see no evidence of panosteitis on this film. However, if we direct our attention to the region below the trochlear notch adjacent to the medial coronoid process, once again, the appearance of sclerosis is apparent, and it's more pronounced in the right elbow than the left. With this information in hand, we sought to get more detailed information regarding probable medial coronoid process disease with a CT scan. Here we can see fragmentation, perhaps in situ fragmentation of the medial coronoid process along the radial incisure of the medial coronoid process, adjacent to the radial head. On transverse slice imaging of the same right elbow, again we can see the evidence of in situ fragmentation along the radial incisure of the medial coronoid process. With this imaging of both elbows, we made a diagnosis of bilateral medial coronoid process disease, but with fragmentation of the right medial coronoid process that coincided with the right thoracic limb lameness. And while the diagnostic imaging and its interpretation is certainly interesting, in actuality, the lameness diagnosis for this dog all began with a good examination of the dog's gait and then orthopedic palpation. Hi, today you're going to learn about infraspinatus contracture. This is a condition that commonly affects medium-sized hunting dogs. While it most commonly affects them unilaterally, it can, as in our patient today, affect them bilaterally. Note the characteristic circumducting gait that occurs during the forward swing phase, and there's also often an associated carpal flip sort of appearance. Though it may not be a perfect description, some describe this as a floor scrubbing gait. The good news with this particular contracture is that if the infraspinatus tendon can be completely transected and released from the underlying shoulder joint capsule, normal limb use can be restored. Hi, let's take a moment to look at a few patients with bilateral craniocruciate ligament disease and characterize their gait as well as their sit test. Here you see a patient with her head held very low and her thoracic limbs pulled caudally so as to shift her center of mass toward her thoracic limbs and away from her pelvic limbs. When asked to sit, she employs a similar strategy to protect her hind limbs from excessive loading. She not only does all the work of sitting with her thoracic limbs, but she carefully avoids full flexion of her painful stifles. With time, this compensatory response will cause her to develop significant atrophy of her pelvic limbs and large shoulder muscle mass. Here's another patient with bilateral cruciate ligament disease who extends her neck forward and pulls her thoracic limb backwards, almost to be a teeter-totter to unweight her pelvic limbs, and once again, certainly doing her best to avoid full flexion of her stifles that are quite uncomfortable.
Okay, class. Just now they show about the thoracic, right? Okay. Okay. So just now we show about the thoracic limb. The thing also is the same. Start with a couple first, and then go to the elbow, and then go up to the shoulder. Okay. So what you need to do is palpation is one thing, and then flex and extend to detect where is the pain, and then after that you have to slightly rotate outward and inward. Okay, to see where is the pain. So in conclusion, your physical examination on the four limbs, right, hind limb or forelimbs, you need to be very good in your anatomy. Okay, what structure you are palpating, what muscle group that you are palpating. Just now, for example, Professor Rose actually mentioned several times about the pectoral muscle. Do you know exactly where is the pectoral muscle? Any one of you? Do you recall what is the pectoral muscle group, and then where is it attached to? Hello, can you hear me? Seems like it's working. Siti? Yep.
Yeah, Doctor.
So, do anyone actually can describe what is pectoral muscle?
Doctor,
Uh-huh.
I'm not very sure, but I think the pectoral muscles are roughly like the chest muscles of the dog.
Yeah, but it's a group, okay? They have the deep pectoral muscle, they have the superficial, and then they have the subclavius, things like that, okay? So if next time you want to become an orthopedic surgeon, you must be very, very good at all the anatomy, ligament, tendon, muscle, bones, okay? So that is a requirement for it. Okay. So that is one. And then second thing, just now I show you the classic gait for the infraspinatus contractile. That is not so common. Okay. So far I only saw once in my life. Okay, I only saw one case in my life. It's a very classic type of movement. You can see the limb actually rotate and go to the one round and come back. Okay, the thoracic limb, the gait. Okay, and then second thing is a cranial cruciate ligament. Just now, that is a classical that you must know. Okay, what is a gait? Okay, so at the end of the lecture today, you must know how to do the tibia thrust test, withdrawal test, and then also Otolani test. Okay, so now I share with you again the the video of it. Okay.
Today I'm performing the cranial drawer test under general anesthesia as part of our standard protocol before entering into the operating room for surgical stabilization of this right stifle. I'll begin by placing my thumb on the fibular head. As I do that, I'm going to roll the soft tissues, including the fibular nerve caudally, away from the fibular head. Next, I'll place my finger on the tibial tubercle, capturing the right tibia within my right hand. Now I'll place my left thumb behind the lateral fibella, again rolling the soft tissues off of it. And finally, I place my left index finger on the patella, again isolating the femur within my left hand. Now I'll use my left hand to stabilize the femur as I translate the tibia cranially and caudally with my right hand. I'll do this with stifle and extension as well as in flexion. Increased instability in flexion is typical of a partial cranial cruciate ligament tear. And in this patient, I can feel a soft end feel upon cranial tibial translation or cranial drawer sign, but I feel a very firm or hard end feel, a very distinct end point, upon caudal tibial translation or caudal drawer, suggesting integrity of the caudal cruciate ligament. Here I will demonstrate the tibial compression test. It is a test for cranial tibial thrust instability. As I hold the stifle in a standing angle, I place my thumb behind the lateral fibella and I place my finger on the tibial tuberosity. And I'm actually going to squeeze these points together like an X-cap suture to reduce any cranial tibial displacement resulting from cranial cruciate ligament rupture. Now, with my left hand resembling an X-cap suture and the stifle held in a standing angle, I'll use my right hand to simulate weight bearing by flexing the tarsus. As I do so, you can see the cranial tibial translation that occurs with tarsal flexion. Additionally, this patient has internal rotational instability of the stifle upon the tibial compression test. Hi, today we'll be performing the Ortolani test as a measure of passive hip joint laxity in a patient being prepared for a left triple pelvic osteotomy. The patient is in right lateral recumbency and the hip is being held in a neutral position, neither in extension nor flexion, neither internally nor externally rotated. The examiner's right hand is placed upon the dorsum of the patient. As a force is applied with the left hand, which is cupping the stifle, the force is being applied up the axis of the femur. As that force is applied, subluxation occurs initially, though it is oftentimes not palpable. As the force is maintained, the hip is abducted until reduction is felt here at approximately 25.8 degrees. The force is maintained up the axis of the femur until subluxation recurs. Let's show this again with slow motion. So this patient has a very distinct positive Ortolani sign with an angle of reduction of 25.8 degrees. In the juvenile stages of canine hip dysplasia, patients' hips will subluxate dynamically. Now here's a test you've probably never heard of. Rather than using the Ortolani test as an indirect assessment whether or not you can induce hip subluxation, why don't you use a more direct assessment, the bookend test, to determine whether or not the patient who's standing in front of you indeed has subluxated hips. One clue that the hips may be subluxated is the prominent greater trochanters, as you see here, creating a boxy conformation to the hind end. The bookend test involves applying a lateral to medial pressure on each of those greater trochanters to see if you can reduce those dynamically subluxated hips. This French bulldog has the boxy conformation that suggests bilateral hip subluxation, and indeed here you can see reduction of the right subluxated hip. By relieving the pressure, the hip subluxates once again. Sometimes I will sway the dog's pelvis back and forth to create the recurrent subluxation. Hi, in this video you're going to learn to measure shoulder abduction angle as a means to detect medial shoulder instability. This maneuver can be performed in the awake animal. However, if there is discomfort and I'm highly suspicious of medial shoulder instability, I may well repeat the maneuver with the animal sedated, and this is oftentimes done in conjunction with diagnostic imaging. So here we have an animal who is sedated actually on a radiography table. The shoulder is held in full extension, while with my left hand I'm holding the scapula firmly against the chest wall as I abduct the shoulder to its maximal extent. This can then be measured with a goniometer or a Carpenter app on a smartphone, as is being performed here. This measured shoulder abduction angle and the character of the end feel of maximal abduction is compared to the contralateral limb. Any shoulder abduction angle greater than 45 degrees, especially if the difference relative to the normal shoulder is more than 20 degrees, is considered suspicious.
Okay, so any questions until now? You must know drawer test. You must know tibia compression test, or also known as a tibia thrust test. And then you must know Ortolani test. This is a 3 special tests for the hind limb. Okay, the Buchan one, not very common, and then sometimes you can get false result. Okay, most of the dogs that presented to our clinic, they are very nervous, so sometimes it's quite hard to make them relax and then we perform the Buchan test. Okay, and then the shoulder instability, normally when they present with a tendinopathy, shoulder tendinopathy, or synovitis, they are very painful. So you cannot do that without the general anesthesia. Okay, so normally I don't really do it. Okay, if let's say the animal under the general anesthesia, then only we try to perform it. Okay, is there any questions from you all? No? Eunice? Yes? Siti? Mira? Anyone want to ask any questions? Everybody?
Oh,
Huh?
okay. None from me, doctor.
Yeah. Okay. Mayapa, you understand, yeah, the content? The roles, Professor did speak very clear, right?
Yes, doctor. So far, able to catch the main points, but maybe need to see back a few of those tests in a slower speed, so I can catch what he's trying to do.
Can. You can actually can find all those test video on YouTube. There's a lot of them. Okay, Otolani, drawer test, trust test. You can find it on YouTube, no problem. Yeah, the advantage of this Professor Ross Palmer punya video is only they have compare, like just now the general orthopedic, they have the comparison between the normal and abnormal. Itu saja. Okay, but for the test, as long as you know the name, then you can search on in YouTube later, and then we can practice it when you come to the clinical rotation. Okay, now the next things that I want to show you is how to do injection in the intra-articular, okay, especially at the tarsus, at the carpal. So I only show you like 2 videos like that. Okay, when the injection points, right, is the same point that you actually will do the arthrosynthesis. So as long as you know where is the anatomy location, you can put in the needle. That is a place that you can do injection. That is a place that you can take the synovial fluid as a sample. Okay, you need the cytology of it. And then sometimes in the bacterial osteomyelitis, you might need to get some sample from the fluid to go for the bacterial culture. Okay.
In order to prepare for intra-articular injection, sterile gloves should be laid out so as to create a sterile field. Several syringes should be placed upon the sterile field. One syringe is for joint fluid collection, and the other is for administration of the intra-articular medication. Needles should be of appropriate length for the joint to be injected. Hip joints and shoulder joints requiring longer needles than the more superficial joints such as the carpus and tarsus. I've gone ahead and opened up the surgical gloves, and I've placed a couple of the syringes on the sterile field created by the gloves wrapper. Now I'll go ahead and don one of the gloves at this point. So since my nurse is occupied getting the patient ready for the procedure, I'll go ahead and use my non-gloved hand to uncap the needle and then go ahead and place it on the syringe. And then I'll basically do the same thing with a medication vial. This medication is pretty viscous, so I'd probably be better off using a slightly larger gauge needle. Now I'll go ahead and don that second pair of gloves, and that way as soon as my patient is ready, I'll be ready to go ahead and perform the joint fluid collection and administer the intra-articular medication. To prepare the patient, the hair over the injection site is clipped. It's important to remember to include all of those pertinent palpation landmarks within the field, and then a routine pre-surgical scrub is performed over this site. Reversible sedation is typically used for the procedure, and with just a little bit of practice, this becomes a very routine outpatient procedure. Accessing the shoulder joint may not be as difficult as you think.
We're going to start off by palpating the acromial process of the scapular spine and the greater tubercle of the proximal humerus. From these two palpable landmarks, we will take our 1.5 inch 22 gauge needle and we'll walk the needle right off the distal margin of the acromial process. From this location, we really shouldn't need to angle the syringe and needle significantly. It's pretty much a straight shot into the shoulder joint. We'll typically administer a heavy reversible sedative to our patient and position them in lateral recumbency. For orientation, this is the cranial portion of the shoulder joint. This is caudal, this is proximal, and this is distal. I've asked my assistant to apply gentle traction to the limb and being careful not to abduct or adduct the shoulder joint. And here I can feel the greater tubercle of the humerus. Here's the acromial process. I can feel just a little depression distal to the acromial process, and I'm going to place my needle at that level. I'm going to go straight in. If I hit bone, I'll walk the needle slightly until I can feel it fall into the joint. And there we go. It's in the joint at that point. Now I'm going to go ahead and change the camera angle here. The dog's head is to the right and the tail is to the left and the dorsum is at the top of the screen. You can see the orientation of the syringe and needle pretty much straight into the shoulder joint. We're going to go ahead and aspirate back, and here you can see that we're getting joint fluid aspirated quite easily up into the syringe. You can see the joint fluid has kind of a pinkish tinge. Before we do an intra-articular injection, we're going to look at this joint fluid grossly. We might kind of subjectively evaluate its viscosity. You can see it's got reasonable viscosity. It might be a little bit thin. We may even want to look at it cytologically before we do an intra-articular injection. Now, once we've determined it's appropriate to give an intra-articular injection in this shoulder, we'll go ahead and hook up our medication syringe firmly to that needle, and even though I'm quite confident we're in the right spot, we'll aspirate back just to be sure. Then we'll go ahead and give the injection, and if we are in the right spot, there should be very little resistance to this injection. What resistance I am encountering is primarily related to the viscosity of the medication through a relatively small gauge needle. So then we pull the needle and we can run this shoulder through a range of motion to disperse the medication, and really it's as easy as that. It's a relatively simple technique. Now at this point we could reverse the sedation and the patient's ready to go. Okay, here we have our carpus prepped for an intra-articular injection. So you can see we've shaved the dorsal surface of the carpus. And we're going to go ahead and flex the carpus and just use that to help us feel the high motion joint of the antebrachiocarpal joint. And typically we can also feel the extensor tendons, the extensor carpi radialis tendon being a little bit more medial, the commondigital extensor tendon down the center. And when we do our arthrocentesis, we're going to try to go right between those two tendons, make sure also that we avoid the accessory cephalic vein. So again, palpating the high motion joint. You can feel it's really relatively large when we flex the carpus like this. Should not be very deep, and we're just going to go straight in. If we hit bone again, we can walk our needle around a little bit just to make sure that we're in the joint. And then aspirate back. And there you can see we're getting joint fluid, which confirms proper placement or intra-articular placement of the needle. Go ahead and connect our medication syringe, and we'll make that injection. And you can see it's really handy to have an assistant, because whereas when you just do a joint tap, you can usually do that with just one hand and you can hold the carpus in the other hand, but when you're switching from an aspiration syringe to a medication syringe, it is sure nice to have that assistant there for you. And then your assistant can just go ahead and run that through a range of motion, once again to disperse the medication. In order to prepare for intra-articular injection, in this case of the hip joint, we'll go ahead and shave the site of hair and we'll scrub it with pre-surgical scrub. And I'll typically don a pair of sterile surgical gloves to perform the procedure. I'll use this bone specimen in order to highlight the critical elements of the hip joint injection. Notice that the dog is in lateral recumbency. And I'll go ahead and ask my assistant to put gentle traction on the limb to help open up the joint space. Now notice I don't want the hip to be abducted, as this will occlude the joint space, make it more difficult to get the needle into the joint. So our needle will be walked off the proximal or the dorsal margin of the greater trochanter and directed essentially straight medially, perhaps a very slight cranial direction to the needle. So the prepared field should include the greater trochanter because it's the primary palpation landmark that we use when performing this procedure. Now on a dog who's a little, shall we say, plump, it can be helpful to have your assistant flex and extend the leg, and this will make palpation of the greater trochanter a little bit easier for you. So here I can feel the dorsal margin of the greater trochanter. We're going to take our 1.5-inch needle, which is probably just going to be long enough in this large breed dog. Maybe a 2.5-inch needle would be better. We're going to direct it straight medial, and there it feels like it's popping into the hip joint. Aspirate back. We're getting a little bit of joint fluid, so that wasn't too bad, huh? Now, as we change our camera angle here, you can see that I pretty much hubbed this needle, and so a 2.5-inch needle might have been a little bit better choice on this dog. Anyhow, we were able to get there with an 1.5-inch needle, but just. So again, here we've got a great sample for synovial fluid analysis, and we're for sure going to look at it grossly. If there's any turbidity whatsoever, I'm probably going to look at it cytologically before I inject this hip joint. Once we've deemed it's appropriate for injection, our medication syringe goes on, aspirate back, confirm we're in the right location, and we'll go ahead and inject the medication into the hip joint. Once that's in, we can pull our needle, and again, we'll disperse the medication by running the hip through a range of motion. Actually, the hip joint isn't as bad as you might think.
Okay, so just now is an example that I actually put in the needle into the shoulder joint, into the carpal joint, as well as in the hip joint. Okay, intra-articular joint injection. One thing is you need to collect the sample for the cytology and as well as for the culture. In a normal joint, the joint sample that you can collect is very limited. Okay, it's most probably in a normal local dog maybe less than 0.5 ml. But whenever there is disease or there is an injury or there is a trauma, there is an infection, the synovial effusion will occur, and then you can get more than 1 ml, no problem. Okay. So that is for the synovial effusion case. And then normally, nowadays, right, normally the medication, the injections inside that either is steroid or is an NSAID, okay? Or some, last time they actually inject the hyaluronic acid into the joint space. And then nowadays, the stem cell treatment also become more and more common intra-articularly. That's why you need to know how to do the skill. You are DVM4. So later on, when you come in for the practical, for the surgery class, after the surgery, you can practice on the carcass, okay? On the carcass, right, if let's say it's already sometimes the animal dead already, most of the time you hardly you can get anything. Okay, but you still practice how to palpate the joint, and then how is it feel when the needle pass through the joint. Okay, at the end of the class you can try, or before the class you can ask for the permission from Dr. Lokman or whoever to try. Okay, so later on I will give a list of the must know physical examination test to CT, and then she will distribute to the class. Okay, I apologize for some technical mistake today. Okay, hopefully it will be okay. And then I see a lot of people actually they actually panic in the waiting room, but no worries about it. I will give out the link so that you can you can find. And then I also give you some website for the YouTube, which I normally show to my student as well. Okay, it's not exactly the same video, but actually it will help you to know what is the topic they need to know. Okay, if no questions, then we meet when you come back again for the practical. Okay, that means that means you'll come back next week, right? 8 DVM4 come back already, right?
Yes.
Okay, can't wait to see you all. Okay, bye. I understand that you have class at 4, right? So so see you next week. Okay, bye.
Okay,
Thank you,
thank you so
doctor.